Two surefire ways to get me all worked up are first, put me outside in an area that has lightning strikes. Supplement plans can be issued. We are going inside. Second, put out misleading information that is meant to scare seniors as a way of marketing. So in this video, I'm going to go over the Medicare disadvantage craze that, like lightning for me, gets people worked up. I need to warn you right now, there is information in this video that, how do I put this? It will make those who hate Advantage plans unhappy. I'm going to use actual data rather than anecdotes and fear tactics. So if you know in your mind that it doesn't matter what kind of evidence is presented to you and you will never stop your pursuit of trying to eliminate Advantage plans, now is probably the time to move to a different video. When I present this to people who hate Advantage plans, they don't like it, and it inevitably leads them to say something about how I'm bought by Advantage plan insurance companies. I'm not, but I will dive into that at the end of the video. There are two glaring problems that people have with Medicare Advantage plans. The most common type of comments that we get around them are that they will deny everything until you die. So we'll talk about prior authorization denials, how often they happen, and how likely you are to be improperly denied. The second big problem is networks. The comments are that all of the best doctors refuse Medicare Advantage plans, you won't find anybody to treat you, and hospitals are dropping Medicare Advantage plans left and right. So I'll go over how Advantage plans contract with hospital providers and how that all works. Okay, let's get the big away first, and that is denials. There is one study cited more than any others around Medicare Advantage plan prior authorization denials. It's been cited by the New York Times, it's been read in Congress, it is being used as proof that Medicare Advantage plans are evil. There are a few things that I feel are wrong about this study, which is fine, as people may feel differently, but there are a few things that I know are wrong in how it is being used. This study is from 2019, conducted by the Office of Inspector General, that took a sample of prior authorization denials, not all prior authorizations, but a sample of 247 prior authorization denials from 1 week spanning June 1st to June 7th in 2019 from 15 Medicare Advantage plans. To give you an idea of how many prior authorizations were submitted that year across all Medicare Advantage plan companies, it was 37.1 million. I'm just trying to help us all see how solid our conclusions can be here on 247 denials from 1 week 5 years ago from just 15 Advantage plan companies. This study proposed to answer the question, how many prior authorization denials should have been approved? In other words, how many would have been approved if the individual were not on a Medicare Advantage plan and were on original Medicare instead? They came to the conclusion, based off of the 247 prior authorization denials that they looked at, that 13% of those, so 32 of the 247, met Medicare coverage rules. In other words, these services likely, and they say likely, not definitely, would have been approved for these beneficiaries under original Medicare. Look, I'm the first person to jump to the defense of those who have been improperly denied care. Insurance companies have a responsibility to insure the people that they have agreed to insure and are receiving funds for from the federal government. A 0% improper denial rate is the ideal. But now let's look at what this really means, because the news outlets and Congress, they twist this to spread the message that 13% of all cases are being denied, and your odds of being denied life-saving treatments are 13%, and you would never be denied if you were not on an Advantage plan and on original Medicare instead. This is blatantly false, not just a simple whoopsie, but an outright lie. So those using this study in this way are either, number one, they're not reading it and they're not able to understand the conclusions. We'll chalk that up to just ignorance. Or number two, they know what they are doing and they are spinning this in a way to make you angry and get you to support whatever their agenda is. I have another study to show you that I feel is more important and accurate, but let's just clarify this OIG study really quick. 13% of their sample size likely would have been approved had the individuals been on original Medicare. Look at the other side of that figure. 87% of the prior authorization denials were properly denied and likely would have been denied on original Medicare as well. Original Medicare's prior authorization process is different, but original Medicare can and does deny payment for procedures that are not deemed medically necessary. Okay, keep this study in mind as we move on to the next. The Kaiser Family Foundation puts out their own study each year looking at all prior authorizations, both approved and denied, from all insurance companies across the country and puts out the total number and percentage of denials. not whether they should have been approved or denied, just the total number. Because of the complexity and the size of this data, they are usually a couple years back. So the most recent one we have is from 2022, which is better than 2019, but it's still a couple years back. In the most recent version that we have, where would you guess the total denial rate is? 13%, like the other study suggests? Maybe higher? YouTube comments, news headlines, and social media outlets would suggest that it is a crazy high percentage. Have a number in your head? The number is 7.4%. Is that higher or lower than you expected? 92.6% of all prior authorizations are approved on the very first submission. Now, of those that were denied and then appealed, 83.2% were overturned and approved. I have links to all of this in the description, by the way, if you want to go through all of this yourself. The Kaiser study actually breaks it down year over year, as well as by insurance company, which is why I always say use an agent, because the company that you pick and where you live matters. Okay, again, my job here is to present to you the facts of how these plans work based on the actual data that we have. 50% of people on Medicare right now are on Advantage plans, and they are bombarded by these anecdotes of issues. And let me be clear, issues do happen on Advantage plans. Insurance companies mess up. Advantage plans are not the same as original Medicare and a supplement plan. But I know that a large percentage of you watching this are already on an Advantage plan or you're considering one, and you would like to know how they will cover things like in this video and not be hit with how you made the wrong choice or you're just going to be denied until you die. So taking the study that everybody is citing and combining the conclusion with the more accurate study no one is talking about, we can make a guess at the odds that you would be improperly denied a prior authorization on an Advantage plan. We take the 7% of total denials, we assume that 13% of those should have been approved based on the first study, and that means that you have a 0.96% chance of being improperly denied on an Advantage plan. And of those, if you and your doctor appeal the denial, 83% more will be approved. But why do we even need prior authorizations? My doctor knows better than an insurance company what I need. Why do they need approval to treat me? Well, you're probably not going to like the answer. As is the case with most things in life that involve humans, there is a very small percentage of the population that does stupid and immoral things. Prior authorizations exist to prevent inappropriate medical procedures from being done. Specifically, prevent the costs of inappropriate and medically unnecessary procedures being paid for by you, the taxpayer, via insurance companies who take on the risk of people and are paid by the federal government. I just looked at the summertime here in 2024 at the Medicare fraud settlements. So from May 2024 through August of 2024, individuals including physicians, hospital systems, skilled nursing facilities, home healthcare and hospice providers, and pharmacies have been convicted for $3.182 billion in Medicare fraud, just in those 4 months that I looked at. A handful of individuals and companies improperly submit claims, costs, procedures to Medicare and are initially approved until they find out it was fraud. Managed care, which is Advantage plans, while not perfect by any means, and whether we like it or not, is a way to try and prevent Medicare fraud from happening. And one of my biggest frustrations with Medicare Advantage plans is how they handle skilled nursing care. They make it quite a hassle because they are trying to ensure that the patient is improving. And of the 24 cases that made up that $3.182 billion in fraud, a large number of them were those from skilled nursing and hospice care facilities. The point I'm trying to make here is that the Advantage plan in the news plays the role of the bad guy, when in reality there is more than one bad guy, and they are all pointing fingers at each other. The other point I'm trying to make is that the odds of you getting denied, period, are much smaller than most people realize, and then the odds of you improperly getting denied are incredibly small. Also, in the years since both of those studies and moving forward, the federal government continues to enact laws and rules for Medicare Advantage plan insurance companies that make their policies more beneficial for you. For example, starting in January of 2024, so this past year, what is called continuity of care rules were put in place for Advantage plans. What this means is that if I got a prior authorization approved for a treatment I'm having, and I switch Advantage plan companies, like during the annual enrollment period that is from October to December, if I get a new Advantage plan that starts in January, the new company must honor the prior authorization for the treatment I was getting before on the previous Advantage plan. Also in 2024, more strict rules around Advantage plans being required to follow traditional Medicare rules, and if there's something that falls outside of those, the Advantage plan must articulate clear internal guidelines that are appropriate, and then the company is required to have a utilization review team to ensure that they are complying with federal guidelines. Beginning January of 2026, several rules are coming through, but one that I feel is great is that Advantage plan companies must respond to a prior authorization request within 7 days. It's currently at 14, and then within 72 hours for urgent matters. Look, this is a problem for me. The time that it takes from a submission of a prior authorization to the thumbs up or thumbs down is a problem. It's one that they are working on, but it is a problem. In 2026, the data streams for Advantage plans and providers are required to be more streamlined to make the whole process even faster. So if you're on an Advantage plan or you're considering an Advantage plan and the prior authorization dialogue in the media has you scared, well, now at least you have some real data behind it. This does not mean that I think that everyone should go on an Advantage plan. There are a lot of things to consider, like networks. So let's talk about the network problem. Again, looking at YouTube and news articles, the headlines state that doctors and hospitals are dropping Medicare Advantage plans left and right. Okay, let's look at that. An insurance company that offers Medicare Advantage plans must have a minimum number of providers that are defined as in-network to offer that plan in certain areas. Remember, Advantage plans are zip code specific. The way that works is that the insurance company approaches the hospital system and the providers and says, we have 10,000 people that we insure in your area, or maybe it's 100,000 or 1 million. In general, the more people the insurance company has, the more negotiation leverage they have. But they say, hey, we have a bunch of people. We would like your providers to be in network with us because then our people will go to your hospitals, use you for healthcare, you stay busy, and you make money. The hospital says, great, how much will you pay us? If you've seen any of my cost comparison videos, you know that there is a billed amount for services, and then there is a negotiated or approved amount from Medicare or the insurance company. So the insurance company says, we want a discount because we have so many people, we will pay you this much. The back and forth commences, and if the hospital system feels like the money that the insurance company is willing to pay is enough, they say, great, we are in network with you, and a common contract length is about 3 years. It can be different, but it's usually for a set amount of time, and then they'll renegotiate later. If the amount is not enough, the hospital system says, no thanks, we will not be in network. This happens with every insurance company. To just name a few, United, Humana, Aetna, Regent, Cigna, which recently got bought. Every insurance company has these negotiations. Their contract lengths, so 3 years, 5 years, 1 year, they're all different. They're also staggered, meaning that United's contract doesn't necessarily expire the same year that Humana's does or any of the other insurance companies with the hospital, and these negotiations are happening all the time. As you can imagine, the hospitals are always saying, you don't pay us enough. The insurance companies are always saying, we're paying you way too much, and the love-hate relationship is exhausting. Well, let's assume that we're dealing with a 3-year contract. I don't know if you remember what was going on 3 years ago, but I seem to recall a worldwide pandemic that disrupted the world and the healthcare system in several ways. Number one, providers, nurses, frontline healthcare workers went through hell. Lives were lost, the stress and the work-life balance was absolutely miserable. As a result, many healthcare workers left the industry, and there was and is a provider shortage. To get a healthcare worker now versus 3 or 5 years ago is much, much more expensive. Also, elective procedures were shut down for a time, and as those reopened and people were able to seek care in 2021, 2022, and forward, the utilization of the healthcare system has increased dramatically, meaning not only have the cost per procedure increased dramatically, but also the number of procedures. This is one reason why those on supplement plans are seeing very high rate increases from 2024 and coming in 2025 as well. But for this conversation of providers and being in network, the 3-year contracts that expired in 2023, 2024, they were made back in 2020, 2021, and are up for renegotiation. With one insurance company that I spoke with, the hospitals are asking for a 40% raise on what they're being paid, or else they will go out of network. The hospitals want more money, which includes the ease of payment, right? So the ease of prior authorization processes, the payment approvals, getting the money, but they also want the amount of that money to be higher. Couple that with the increased healthcare utilization, and now the insurance companies also have a decision to make. Do you pay 40% more per procedure? That is a huge increase, by the way. Plus, you are having more frequent procedures because people are using healthcare more, or do you allow the healthcare system to drop out of network? And that is what we are seeing take place. This happens every single year, by the way, but given that we are in election year, it gets even more attention, and the headlines say that everybody is dropping Advantage plans, but that's not even remotely true. Most of the hospital systems referenced are dropping an Advantage plan with one or two insurance companies, not all Advantage plans. There are some hospital systems dropping all Advantage plans, but the vast majority that you are hearing about are dropping a specific company because those negotiations came to a point where the hospital was asking too much from the insurance company, or the insurance company was proposing too little in the form of payment. I'll just run through a few of them. Essentia Health in Minnesota is no longer in network with United and Humana in 2025. That's not all Advantage plans, but it is with those two insurance companies. Blessing Health in Illinois will only accept Blue Cross Blue Shield, United, Molina, and Total Retiree Advantage Illinois. Again, that's not dropping all Advantage plans, it's which companies have a contract with them versus those that don't. LMH Health in Kansas is no longer taking Aetna or Humana. Northern Light Health in Maine is no longer taking Humana. So notice that number one, these are geography based, and number two, they are insurance company specific. In certain areas and with certain health plans, they are accepting or no longer accepting certain insurance companies. Every year, they can also bring on new insurance companies that were not in network before, but they are now. Those don't make people angry, so they don't get the news articles written about them. Now, in this list, there are 3 hospital systems that stopped all contracts with all Advantage plans: Kimball Health Services in Nebraska, Brookings Health Systems in South Dakota, and Scripps Health based in San Diego, California. There are other systems that stopped working with other Advantage plan companies before 2025, and then there are others that only accept their own Advantage plan, like the big one, Kaiser. Picking an Advantage plan company is important, and even if you pick one that is in network with your providers today, if contract negotiations don't go well when it's time for companies to renew, then next year you could see your providers being out of network and either needing to find new providers or pay more to see the ones you want, or get a new Advantage plan. So my point on the network section is that it is a real thing. Working within a network is a part of the Advantage plan experience. It's one reason why most Advantage plans have $0 premiums and supplement plans have higher monthly premiums. With a supplement plan, you are paying for more access and freedom. With an Advantage plans, you are not paying monthly, and so you are working within that plan's network and rules. The point of this whole video is do not make your Medicare decisions from a YouTube video, including mine, and do not make your Medicare decisions based off of news headlines. There is a ton of research around this. People want to be angry. Headlines and videos and articles that create anger and fear are more likely to be clicked, they're more likely to be read, and they're more likely to be shared. They are also more likely to get people to rally around a cause, even if that cause is not true. Again, in an election year, this gets ramped up even more. Please don't form your opinions on headlines and sound bites. Take the time to research the actual studies, the data, and the articles. You can also subscribe to this channel where I attempt to do that for you, and I will link to the sources in the description of everything that I'm referencing. Now, let me finish by addressing those who say that I'm bought by Advantage plan insurance companies. I have never accepted a single penny from an Advantage plan insurance company to make any sort of video or opinion on a video on this channel. If I ever accept a sponsorship of any form, I would tell you what it is, and then my acceptance of that would be conditional on me being allowed to say whatever I want about the topic and not what any company wants me to say. Others will say, Eric, you're only saying this because you make more on an Advantage plan than a supplement plan. Well, at this point in what I do, I am on YouTube full time. I do not meet and place you with the plans at this point. I have partners who are better than me who help individuals find and pick their plans all across the country. I am licensed, but your experience is better with my partners because for one person like myself, to be licensed in every state is not what's best for you. Being licensed in a state and then being familiar with that state are two very different things. You are better off using my partners who are both licensed and familiar with the plans and the hospital systems and things going on in your specific state than me or some other agency that is just licensed in that state. I do not ask my partners what plans they are putting people on. I do not have any sort of quota where they should be putting more people on an Advantage or a supplement plan or any specific insurance company. I have worked with these partners for years and I trust them with my life to do the right thing for you. I will not bring on a partner if I do not believe that they will do what is right by you and then they're chasing some sort of a commission check. We have more people on supplement plans than Advantage plans at this point. I want you on the plan that is right for you, not the plan that is right for an agent's commission. And sometimes an Advantage plan is right for people. Other times it is not. All right, the secret code word is a little tradition on this channel. If this is your first video with us, it helps me manage the hate comments. If you sneak in the secret code word to your comment, then I will be able to know that you've made it this far, and then I can take your comment more seriously. The secret code word for this video is fox. I used to have a dog that looked a lot like a fox, and when dealing with the media, there are a lot of clever foxes circling the henhouse to try to get your attention. Now, I'm working on a video that is going to go over how there are Medicare Advantage plans that are completely leaving the market in 2025 because of the Part D changes, and people on those plans need to switch to something else before the end of the year. It should pop up right here. If that's not the right video, it's because it hasn't been recorded yet. If it is the right video, then we're golden, and I will see you over there.